Eileen, is your cat walking across your keyboard?
No, that's actually not me. That's someone hiding behind the CME code name. They don't trust me with important things like recording. All right, well, it is 12:04, so while people continue to join, I'll just start with the housekeeping stuff at the beginning. So welcome everybody to our Friday CFAR conference. Couple of just housekeeping notes. So next week is going to be the opportunity for in-person nourishing CFAR conference, nourishing both in the presence of Dr. Joel Gallant to talk to us about enteroviral resistance and also pizza. There will likely be on the announcement an indication for to let us know if you're going to attend, just so we can plan well for that. But you can come either way, and we will also have a virtual option because I know not everybody can travel to Rangos to be at the meeting. So looking forward to that. And then also upcoming later in May, Dr. Todd Brown for diabetes, and then we're working on a measles session as well. So without any further ado, I will introduce Dr. Matthew Hamill. He is an associate professor here at Johns Hopkins with an appointment also at Bloomberg. He did his medical training in the UK and then did research in Soweto, South Africa for, I think, 3 years, and has dedicated most of his professional life to being just the absolute expert on what to do for STIs. And for many of us who have the privilege of working with him in the clinic, always willing to answer questions, always willing to participate in the joint angst of managing different patients. And we're just so thrilled to have your expertise today.
Thank you, Eileen. Thank you for that really warm introduction. It's a real pleasure to talk about some of the things that have been preoccupying me in terms of syphilis over the last couple of years. I trust that you can see my slides okay.
Yes, your slides look great.
And you can hear me okay. I'm sort of looming in because I realize that my voice is a little soft and my microphone isn't fantastic. So please let me know if you can't hear.
It sounds good.
All right, great. Okay, so here are my disclosures, and there are some objectives listed here. But really what I wanted to do was to share with this group some of the recent advances, some of the great gray areas around syphilis diagnosis and management, and just to help to think through some practical approaches, particularly in the management of neurological syphilis. As usual, in my exuberance around this topic, I've probably put too many slides together. So if we don't get through them all, I think that's fine. The other thing that it would be really important is that if you have a question that you wanted to ask, please do stop me and let me know. Otherwise, I'll just keep going until either time runs out or we get to the end of the slides. So in terms of what's new, I think that there have been some interesting and potentially exciting developments with a new over-the-counter test for syphilis, some data on newer data on oral cefixime and linezolid in the treatment of early syphilis infection, some really very reassuring culture data on doxycycline and tetracycline resistance in Treponema pallidum. But on a less positive note, as many of you will know, the CDC STI reference lab has recently been closed. And, that was a real pioneer, both in terms of clinical diagnostics, evaluating new diagnostic tests, and also providing reference material for dark field microscopy, for example. So we'll start with a case, a clinical challenge. This is a patient who presents to your clinic for routine follow-up. His treponemal chemiluminescence assay, so that's his treponemal antibody, is reactive, and the RPR is also reactive with a titer of 1 to 8. He tells you that he was diagnosed with syphilis a year ago based on a point of care test that was performed when he was at a nightclub. It was a health fair in the nightclub, and he was treated with a single dose of bicillin. So that's the case. We're going to come back to it throughout the course of this talk. I don't have the time really to go through the natural history of syphilis, but the point that I want to make on this slide is that there's this fantastic review in the New England Journal written by Khalil Ghanem and colleagues, and it's a great read. It's very informative. But one of the things that I like most about it is this diagram. And for people who talk to me about syphilis, one of the questions that I'll always ask is, what stage of syphilis does this person have? So this slide is a reminder about how we stage syphilis, and it will become apparent as I go on about why this staging is so important. It really helps inform many of our decisions in the management of syphilis. The next broad point that I want to make, and many of you will be very conversant with this, but for people who are maybe less familiar with syphilis diagnostics, I just wanted to make a couple of points about syphilis serologies. In order for us to make a firm serological diagnosis of syphilis, we need 2 tests to be positive, and typically that is a treponemal test. At Hopkins, we use a chemiluminescence assay. In other organizations, different treponemal tests are used, and I've listed some of them there. There are many different ones. So a secure serological diagnosis requires a positive treponemal test, and ideally a positive non-treponemal or lipoidal test. And at Hopkins, we use the RPR, but the other commonly used lipoidal test is the VDRL. And then in other scenarios where someone has a positive screening treponemal test and negative non-treponemal test, then in order for us to meet that 2 positive test criteria for a serological diagnosis of syphilis, then a second but different treponemal test will be used. And at Hopkins, we use the TPPA. So non-treponemal and treponemal tests work in concert. They're complementary. They have slightly different functions. The point of this slide is to just remind everyone that a treponemal antibody is really fantastic for diagnosing syphilis the first time someone has syphilis. It becomes positive earlier than the non-treponemal test. The drawback is that when somebody has a positive treponemal test, then typically that will stay positive for the rest of their lives. So a treponemal antibody is not useful for monitoring response to treatment, and it's not useful for monitoring for evidence of reinfection. And that's where the non-treponemal test comes in. So with the RPR, it becomes positive slightly later than the treponemal antibody. And over time, the RPR titer will fall. It's important to remember that even without treatment, over time, that RPR titer will fall. So seeing someone with a negative RPR titer or a low RPR titer, we can't make any assumptions that that person has been appropriately treated. The only way that we can do that is by a careful treatment history. So again, the non-treponemal tests will, with treatment, will decline. As I've mentioned, they'll also decline without treatment, but they'll also then increase again if somebody has been reinfected with syphilis. Many of you will know that you can order just an RPR on Epic. So if someone has a previous treatment history, then I would advise you all just to request an RPR. It saves a lot of anxiety on the patients when they look at Epic and they see this positive treponemal test, and then they think that they have syphilis again. So it's much easier and more cost-effective just to order an RPR in someone who's previously had a syphilis diagnosis. So just to go back a little bit to, testing opportunities for syphilis, there are now 2 FDA-cleared point-of-care tests, and this one over-the-counter or at-home test for syphilis. The disadvantage of all of these technologies is that they only provide a treponemal antibody. So in order for us to correctly diagnose and manage patients, we still need to make sure that they have a non-treponemal test. So how do you interpret a treponemal only antibody, either the point of care or the over-the-counter test? So if the test is non-reactive, then one of 2 possibilities. The first is that the patient does not have syphilis. The second is that they have early syphilis and the antibodies haven't had time to develop. So in that scenario, you would recommend to the user that they repeat that test. If they've recently had an exposure or a potential exposure, then they would need to repeat that rapid test for syphilis to make sure that the test didn't miss incubating infection. If the point of care test is reactive, then there are 3 potential scenarios. The first is that it's a false positive test. The second, that someone has treated syphilis, and the third is that they have untreated syphilis. There's no way of being able to discriminate between whether someone has treated or untreated syphilis based on the treponemal antibody. The only way of doing that is by they're looking at their treatment history and also looking at their RPR titers over time. So what do you do with this particular patient who had their positive point of care test, didn't have an RPR, was treated with a single dose of bicillin? I think, as with most things related to syphilis, a good history and physical examination are really key, particularly in excluding any evidence of neurological involvement. I think that there are 2 options here. You could continue to follow the patient and make an assumption that he was previously adequately treated. For me, that doesn't seem a particularly appropriate approach, although certainly one could argue that is one way of interpreting this clinical scenario. I think what I would do, certainly in this scenario, is to offer retreatment for syphilis of unknown duration or latent syphilis, and then retreat. But I would also caution the patient that you might not see this 4-fold decline because we don't know where they started off. They may have had an RPR titer of 1 in 256 at the time that they had that positive point of care test. But as always, in these gray areas, and there are many gray areas when thinking about syphilis management, shared decision making with the patient is really critical. So thinking about what we used to call latent syphilis, and the terminology is changing slightly. So increasingly it's being referred to as latent syphilis of unknown duration, but they're really synonymous. there was a study that was published in STD in March of this year that made me ask the question, do we really have any idea of how to treat late latent syphilis or syphilis of unknown duration? So this was a study from King County, Washington. It was a retrospective cohort where they looked at serological cure, which they defined as a two or greater titer RPR decline amongst people with latent syphilis of unknown duration who received either 1 dose of bicillin, 3 doses of bicillin, or 28 days of oral doxycycline. So these were people who were diagnosed between 2007 and 2020. So of 761 individuals, the median time from treatment to either serological cure or their last RPR was 219 days. And those with high titer late latent syphilis, so that was titer of greater than 1 to 32, that serological cure was observed in 88%, regardless of whether they received 1 or 3 doses of bicillin or oral doxycycline. And for people who had low titer late latent syphilis, then irrespective of the treatment modality, less than 50% met that serological cure definition. So to me, I think what we need is a really carefully constructed randomized control trial looking at different treatment for late latent syphilis. And the question in my mind is, you know, the received wisdom is that we need 3 doses of bicillin at weekly intervals to treat this syphilis stage. But I'm not sure that 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 we don't have good evidence for that approach. It's just something that we do, something that we've always done. And I hope that in the fullness of time, we can do a randomized clinical trial to actually answer the question about what's the best treatment modality for this stage of syphilis that is something that we all encounter very commonly. The next point that I want to make is, or a plea, I guess, is that the importance of rechecking the RPR on the day that the person receives their treatment for syphilis. And the reason that I say this is that in my own observation, but also in this paper that was published in CID a couple of years ago, looking at 766 people with syphilis, and there was a median duration between their initial presentation and the day that they were treated of 6 days. And of these 766 individuals, 15% of them had either a 4-fold increase or a 4-fold decrease in their RPR titer in that week between diagnosis and treatment. So it's a bit like the case that I mentioned before. If we miss the opportunity of describing the peak RPR titer, then we run into all kinds of trouble downstream when looking at serological responses. So it's really beholden on us to provide our patients with the best chance of having serological cure. So I think it's really worth, when that patient comes in for treatment, to ask them to repeat their RPR titer so that we can then really know what the peak RPR is, so that we can then follow the trend over time. So I mentioned earlier some new or newer data on cefixime. This isn't particularly new. You know, we've been thinking about using cefixime in the treatment of early syphilis for some time, but there have been some new data or preliminary results from a trial that was published in Open Forum in February of this year. So this is a randomized, multi-site, open-label, non-inferiority clinical trial. It's currently ongoing. That's comparing the effectiveness of cefixime 400 milligrams twice daily for 10 days to benzathine penicillin at 2.4 million units intramuscularly. And this will be in 400 participants from 12 sites in the US and Peru, including people with and without HIV. So that's the strategy, but there's also a twist, and that is when there's penicillin shortage, that participants who are randomized to penicillin will instead receive doxycycline 100 milligrams twice daily for 14 days. And these individuals are followed up out to 9 months. The primary outcome is a 4-fold or greater decrease in RPR compared to the initial RPR at enrollment. A couple of points to make. As of May of last year, and these are the data that are reported in this study. 134 participants have been enrolled, 67% of whom were living with HIV. Adherence to cefixime is high at 92%, and the data is from 104 participants with follow-up at 3 or 6 months. 52 received cefixime, 45 penicillin, and 7 received doxycycline. And what you can see is that that 85% of those who received cefixime and 89% of those who received bicillin reached that primary outcome, suggesting that there's equivalence between cefixime and penicillin. And as a side note, and the numbers are smaller, but 100% of those who received doxycycline achieved the primary study outcome. So I think that these are really encouraging data and I think it provides us with an alternative in early syphilis to treat people who either are unable to or unwilling to receive bicillin treatment. A less rosy scenario is a study looking at oral linezolid compared with bicillin for the treatment of early syphilis in adults. So this is a small study that randomized people to either BPG or linezolid. The choice of linezolid was surprising to me. It was 600 milligrams once a day only, and given only for 5 days. And the primary endpoint was a composite that used clinical response, serological response, and the absence of relapse. And what you can see is that after 48 weeks follow-up, only 70% in the linezolid group had responded to treatment compared with 100% in the bicillin group. And I think what's most concerning is that 15% of those who received linezolid actually had a clinical relapse of their early syphilis infection. So it's always easy to be wise in retrospect, of course, but I think that unfortunately, the linezolid story in the treatment of early syphilis has been set back many years, partially due to the design of this study. So other things to watch out for, and hopefully this is going to come either later this year or next year, and this is a randomized control trial comparing oral doxycycline versus IV penicillin in the treatment of neurological syphilis. So Khalil Ghanem is one of the PIs on this study, and we will be, I hope, involved in recruiting participants for this study. And I think this could be a real game changer in the management of neurological syphilis. It's something that I'm very comfortable with. In the UK, it's an alternative option for the treatment of neurological syphilis. We use 200 milligrams twice a day for 28 days, but the evidence base for that is really, really very thin. For many years, it was based on a study of 5 participants who received oral doxycycline that was published in 1985. So watch this space for this exciting randomized trial. So we're going to go back to the case now. We've retreated that person who had their nightclub point of care test and treatment, and he's interested in doxy PEP, and you're having a discussion with him about what are the potential implications of doxy PEP on STIs, and particularly around should he acquire syphilis again in the future. So the efficacy data of doxy PEP in men who have sex with men and transgender women is really extremely strong in terms of syphilis prevention. With all of the different studies, it's in the region of 65 to 75% reduction in incident syphilis at an individual level. But there's also impressive population level data. So on the left side, you can see this study from San Francisco that looked at the changes in early syphilis cases among men who have sex with men and transgender women before and after the widespread introduction of doxy PEP. And at a population level, you can see that there was a more than 50% reduction in early syphilis diagnosis within these populations. But what about the 30% who have a breakthrough infection? And here there are many, many more questions than answers. I think the things that I'm concerned about is that there may be attenuation of clinical manifestations, that the rashes may be even more subtle, that the neurological signs and symptoms may be even more subtle. So I think that we really have to be aware of that and have our eyes open for potential attenuation of clinical manifestations, and also the effect that intermittent doxy exposure may have on serological responses. I don't think that we know what to do with interpreting serological tests when somebody is using doxycycline PEP, but I think it's important that we just think about it and that we commune and try and make decisions in terms of management using the best available evidence. But again, I keep coming back to this, I think a really careful history, working with the health department and a careful physical examination can help us with these challenges. So the other thing that I and others have been concerned about is about the effect of doxycycline on emergence of tetracycline resistance in Treponema pallidum. I think what the doxy-PEP studies have showed us is that the doxy-PEP exposure does increase antimicrobial resistance in Neisseria gonorrhea. I think that that's fairly clear. But to date, we have no evidence of chlamydia resistance to tetracyclines. And there are two studies, this one that looked at in an in vitro culture model, and this one that was published recently in JID, which again looked at this in vitro model. Both of these studies showed that if you expose Treponema pallidum to subbactericidal concentrations of doxycycline, that we didn't see, or the authors didn't see any resistance induction. So I think that that's encouraging. We may struggle with clinical diagnosis, we may struggle with serological interpretation, but the available data so far doesn't suggest that we need to worry about tetracycline resistance in Treponema pallidum. Okay, so I'm going to shift gears again and talk about another case. This is a 35-year-old woman with no past medical history. She presents for her routine annual visit to her primary care provider. She was last seen 2 years ago. She's asymptomatic, and she reports that she's had 3 sexual partners in the last 2 years, but she has a new partner with whom she's monogamous, and they've been together for the past 1 year, and she requests STI testing. Her physical exam is normal, but her laboratory tests show a reactive treponemal test and an RPR with a titer of 1 to 32. She also, on careful history, has no recollection of ever having a rash, lymphadenopathy, or any ulcers that would be compatible with primary syphilis. So she's diagnosed as having latent syphilis of unknown duration and is appropriately treated with 3 weekly doses of bicillin. Her partner is tested and his serologies are non-reactive. So at follow-up, she remains well. She has no clinical issues. However, her titers don't shift. For the first 12 months, they don't move at all. And then at 24 months, they've only declined by twofold. So what do we do in this really common clinical scenario where the titers don't behave in the way that we wish that they would? So just a reminder that when we're thinking about serological cure, the mantra is that we require a 4-fold or more decrease in non-treponemal titer at 12 months for early syphilis and 24 months for latent syphilis. And also remember that in people living with HIV who have early syphilis, then the recommendation is that for those individuals, we wait for a full 24 months before adjudicating whether they've had an appropriate serological response. So these next few slides Khalil lent to me, so a big thank you to him. I think that they are fantastic. I couldn't have done them better, so I'm just poaching his slides. So if you have a patient who has a serological non-response, such as this individual whose RPR went from 1 to 32 only down to 1 to 16 after 24 months, the first question to ask is, are there any neurological, ocular, or otic signs or symptoms? If there are, then manage them accordingly. If not, then ask, did you wait long enough for the titers to decline? And sometimes we get impatient with RPR titers. We want to see that fourfold decline very rapidly. And if that doesn't happen, then people can get a little twitchy and they can start offering retreatment that is absolutely not necessary. So the next question is, did you wait for long enough? And if you didn't, then to keep following. And then if you did wait for long enough, then we need to assess whether the patient has become reinfected or is the patient pregnant? And if the answer to either of those questions is yes, then I would retreat them at that stage. But if they're not pregnant and there's no evidence of reinfection, then you look at the RPR titer. If it's equal to or greater than 1 to 64, then you can consider a CSF examination. And the reason for that, or the rationale behind that, is if someone has no evidence of reinfection and they have an RPR and their RPR doesn't respond appropriately, the question is, do they have T. pallidum sequestered in a sanctuary site such as the CNS that has sort of leaked back into the circulation and is causing this RPR response? So then you can consider a CSF exam. If the titer is less than that, then you can just keep following the titers. And the reason for that is there have been 5 observational studies that showed no difference in intermediate term outcomes between retreating for people with serological non-response and watchful waiting. But if you are going to retreat somebody in that situation, then I think that that's completely reasonable. But I would say that that should only happen once rather than repeated every year or every 2 years, which sometimes happens. So let's go back to the case. The patient continues to be in the monogamous relationship, stays asymptomatic. No additional treatment was recommended. We did a watchful waiting approach, and then 12 months later, the RPR has fallen down to 1 to 4, and everyone feels relaxed and relieved about that. However, she comes back a year later for testing, and her titer is now increased to 1 to 16. So the question is, and this is just a different variation, what do you do with titers that have increased fourfold? So the previous scenario is what we do when there has been an inadequate titer response. And this scenario is what we do when the titers have increased. So again, check for any neurological signs or symptoms and treat accordingly. And the next point, I think, is a really important one. So we know that the RPR is fickle. There has lots of laboratory variation. I've frequently seen a sample with an RPR of 1 to 64, for example, and it just seemed completely unrealistic. I've asked the lab to repeat it. So repeat the test on the same sample, and it comes back at a titer of 1 to 2. So there's lots of variation in RPRs, as we know. So what the advice is, if you see this increase, this fourfold or more increase, that you ask the person to return at least 2 weeks later and have that RPR titer repeated. So you repeat the titer, let's say 4 weeks later, and if the titers have gone back down, then there's nothing more to do. You just continue your routine monitoring. But if the titers are still elevated, then I think the important thing to think about is reinfection. And it's all about the way that we ask patients questions, because there's a huge amount of social desirability bias. Patients want to tell us what they think we want to hear. So what I try to do in my practice is to, in a very neutral way, really carefully assess for evidence of reinfection. And if that person has had a new sexual contact, for example, then in that scenario where the RPR titers have increased, then you assume that it's a reinfection and you retreat them. But if there is absolutely no evidence of reinfection and somebody has this serological failure where their RPR titers have increased, then at that point, then a CSF exam is something that we should consider for the reasons that I mentioned previously. But I would say that there are no data comparing outcomes for patients who undergo a CSF examination compared with those who just undergo empiric retreatment with 3 doses of Bicillin without CSF examination. But the 2021 CDC guidelines would recommend a CSF examination in this scenario. So she reports that she has a new sexual partner. She doesn't recall any rashes or lesions. She's treated with a single dose of Bicillin for early latent syphilis. Her partner is tested and he's diagnosed with latent syphilis of unknown duration, and he's appropriately treated with 3 doses of Bicillin. So again, I want to just switch gears slightly to think about some other syphilis management considerations. So this time we have a patient. She's 38 years old. She has well-controlled HIV, diagnosed with HIV 6 years earlier, who presents with a rash, with fevers, chills, a new onset headache, mild photophobia bilaterally, and discomfort and vision loss in her right eye. She has a new partner they've been together for the past 2 months, and sometimes they use condoms and sometimes not. So on examination, she's awake, she's alert, but she is sitting in a dark room. She doesn't have meningism. And at bedside ophthalmological examination, when you try and look in her eyes, you see this haze. And so clinically, it feels like she has an uveitis. She has the skin findings as shown here, but she doesn't have any other neurological findings. She has no weakness. She has no cranial neuropathy. Her laboratory tests, unsurprisingly, show a reactive treponemal test, and her RPR is reactive with a titer of 1:64. So I think that this patient clearly has secondary syphilis based on her dermatological findings. And the question is whether she has early neurosyphilis, early ocular syphilis, or both. So again, I'm going back to this New England Journal diagram. And the point that I want to make here is that neurological involvement can happen at any stage of infection. And it can even happen prior to the onset of the primary lesion. So in some studies that were conducted years ago now, what they showed is that you could find evidence of CNS invasion in 40% of individuals with syphilis, even prior to their developing their primary chancre. So the take home is that neurological involvement can happen at any point of a patient's journey with syphilis. And it's estimated that somewhere between 2 and 7% of people with syphilis will develop CNS complications. I want to provide some sort of tips around ocular and otosyphilis. For ocular syphilis, any portion of the eye from the front all the way to the back can be involved, and anyone with syphilis with ocular symptoms requires an immediate ophthalmological examination. The diagnosis of ocular syphilis is presumptive. If someone only has ocular signs or symptoms, they don't need a CSF examination, and that's because it's normal in 40% of patients. So what we should do is to initiate IV penicillin and get an urgent ophthalmological examination. Otosyphilis, to me at least, is the most difficult stage of syphilis to diagnose. And the reason that I say that is that the clinical manifestations can be really subtle, and patients won't volunteer their symptoms. So it's really important that we ask everyone whether they've experienced any hearing loss, vertigo, or tinnitus. And the reason for that is that the longer someone has otosyphilis without treatment, then the worse their outcomes are. I mean, that's true for ocular and neurological disease in general, but I think particularly with otosyphilis that the hearing loss can be very profound and is only marginally reversible. But again, if someone only has oto symptoms, then a CSF examination is not recommended. And you would just go on and treat with IV penicillin. In terms of prognosis for otosyphilis, then only about 23% will notice improvement in their hearing, but the majority will have improvement in tinnitus and vertigo. So with this patient that I just presented, does she need a CSF examination? I think I've gone through this in various different ways, so I'm going to skip over this slide, but I think the answer to this question is that she does need a CSF examination, and the reason is because she definitely has optic symptoms, but she also has a new headache, and that's something that we need to take seriously in this context. So a few take-homes related to neurosyphilis, ocular syphilis, and otic syphilis is that a normal CSF examination really effectively rules out neurosyphilis, but it definitely doesn't rule out ocular or otic disease. A person who has only otic or ocular signs or symptoms doesn't need a CSF examination, but a thorough clinical evaluation and help from our ophthalmology and ENT colleagues. And if the clinical picture is consistent, then we should start antibiotic therapy. A patient who has both neurological signs and symptoms and ocular signs and symptoms should undergo a CSF examination. That's based on 2021 CDC treatment guidelines. And people will ask me, but why is it even required? You're going to treat them with 10 to 14 days of IV penicillin anyway. And I think that is really a very fair point to make. The CSF exam probably won't affect your treatment decision in this clinical scenario, but it might have important diagnostic considerations. So patients may have other causes for their neurological manifestations other than syphilis, and you don't want to delay diagnosis of their cryptococcal meningitis, for example. So how do we make a diagnosis of neurosyphilis? I think I try and break it down into levels of certainty. So if someone has a reactive CSF VDRL, as long as the CSF isn't blood-stained, then that's what's considered a definitive neurological neurosyphilis diagnosis. If the CSF VDRL is not reactive, but they have pleocytosis, then that is a very sensitive, although not necessarily specific marker for neurosyphilis. And based on the work from Christina Mara and others, then the recommendations is that if someone who is not living with HIV has more than 5 white cells, compared with someone who's living with HIV and not on ART, who has greater than 20 white cells, then that is consistent with a presumptive diagnosis of neurosyphilis in the absence of a reactive CSF VDRL. But if the VDRL is normal, is non-reactive, if the CSF white count is normal, but the protein is elevated, if the protein isn't elevated, then you can say this person doesn't have any evidence of neurological involvement. But if the CSF protein is elevated, and for me, I rarely use CSF protein as a way of diagnosing neurological syphilis, unless it's really elevated and there's no other plausible explanation. But in this scenario, where you have a strong clinical suspicion of neurological syphilis, where the pretest probability is high, so the clinical scenario is fitting and the person's epidemiological risk is right, then what you can do in this situation is to request a CSF treponemal antibody, and the lab will send out for a CSF FTA. And if that test is negative, then you can absolutely feel reassured that the person doesn't have any evidence of neurosyphilis. The difference between the CSF VDRL and the CSF treponemal test is that the treponemal test is sensitive. So some people will say if you have a negative CSF FTA, then you don't have neurosyphilis. The VDRL is only about 50% sensitive, but it is very specific. So again, these two different testing modalities provide different information, and using them together, you can really risk stratify a patient in terms of whether they have neurological involvement or not. There's a small point, and I think that we just don't see really tabes dorsalis, or very infrequently see tabes, but there are a proportion of people who have tabes who will have a completely bland CSF. So again, just bear that in mind. If the clinical picture fits, the serological testing on blood shows evidence of syphilis, and somebody has a normal CSF, but signs and symptoms consistent with tabes dorsalis, then I think it would be important to treat them with IV penicillin, even if they have a completely normal CSF. So this patient that we've been discussing undergoes a CSF exam. The white cells raise, the protein's up, but the VDRL is non-reactive. And she started on IV penicillin with the intention of treating for 10 days. The ophthalmologists who see her request the use of a 10-day course of prednisolone because of her panuveitis. So the question then is, should we be using corticosteroids for syphilis? And again, there are many transatlantic cultural differences in medicine, but when I was practicing in the UK, then routinely we would initiate a very short course of 3 days between 40 and 60 milligrams of prednisone for people with neurological syphilis, optic, otic, or cardiovascular disease. But what I would say is that really there's no evidence to support the use of corticosteroids, but I think many providers in Europe, at least, they do use steroids to reduce inflammation and to also reduce the possibility of a Yerkes-Herxheimer reaction, and particularly at sort of anatomical sites that are contained within a small box, like the brain and the optic nerve. Then if you were to get a brisk Yerkes-Herxheimer reaction with lots of edema, then there could be real compromise to those structures. And again, in cardiovascular syphilis, if you have induced the Yerkes-Herxheimer reaction around the inlet of one of the coronary arteries, then a patient can go on to have a myocardial infarction. All of that said, we don't have data other than anecdotes and experience to support the use of corticosteroids in this scenario. So my final question is whether we should use additional doses of BPG after IV penicillin for neurological syphilis. So my own journey here has really evolved over the last decade. If you'd asked me 15 years ago, I would have said, yeah, you treat them for their neurosyphilis and then you give them 1 or 2 additional doses of BPG after, in order that you get you get the same exposure to penicillin as if you were treating somebody with 3 weekly doses of BPG. So this is in the setting of late neurological syphilis. But really what I've come to realize over recent years is that this is completely made up. I mean, a lot of the things in syphilis are made up, with people who are well-intentioned, using lots and lots of clinical experience, but it's not based on any evidence at all. So I no longer recommend additional doses of BPG after somebody has completed their 10 to 14 days of IV penicillin for neurological syphilis. The CDC say that the durations of the recommended and alternative regimens for neurosyphilis are shorter than the duration of the regimen used for latent syphilis. Therefore, BPG 2.4 million units once per week for 1 to 3 weeks can be considered after completion of these neurosyphilis treatment regimens to provide a comparable total duration of therapy. So nobody is going to criticize you for taking the conservative approach of adding additional doses of BPG at the end of neurological syphilis treatment. But I think that this is something that is really not borne out by any evidence. And in this current era where we do see BPG shortages, then I avoid any unnecessary or additional doses of BPG, and I like to preserve that medication for those people where there's actually evidence of benefit. So I'll finish there. This slide is in recognition of both past colleagues. So the smiling faces on the left are mentors of mine and colleagues in the UK who really influenced my thinking around syphilis and my love of this particular area. And then the familiar faces on the right-hand side of our friends and colleagues here at Hopkins who have taught me a lot and continue to teach me about syphilis. And then on the far right, you see this gorgeous Manet watercolor of periwinkles, and this is the painting that he produced after he was released from a hospital in the 19th century for the treatment of neurological syphilis, which in those days there were many toxic ways of treating syphilis, but his particular ordeal was to essentially have been cooked in order to try and kill off the treponeme. So if you have any questions about any things STIs, then please pick up the phone or email Sue, Khalil, myself, others. There are many others who know about STIs. You can also use this online portal that you can put in any STI-related question, and it will get channeled to one of our local STI experts, and we'll get back to you by email within a day or two. So thanks so much for your attention. We have a few minutes, so feel free to ask any questions or make comments.
Well, Matthew, that was fantastic. Thank you so much. It just covered so much and really answered the questions, not just the guidelines, but the questions that come up so frequently. There has already been a request for your slides. If you're willing to share, we can post them to the teams.
Absolutely.
Okay, great. And then I know that you have a really beautiful recent review, and maybe we can upload that file there as well. so people can access that. So everyone's just saying you're brilliant, but does anyone have an actual question? I mean, that's not a question though. That's something we all know. Oh, like the Guinness cardboard cutouts. So, and Matthew, can I just ask with the home-based testing, do you have outside of like I want the kit, that kind of type of situation, and this initial nightclub diagnosis scenario? So, how often are you do you have patients who you recommend self-test, or how have you been approaching using that?
Yeah, I haven't actually. I haven't used it. I think that it costs, and Yuka, who's on, knows much more about this than I do. I think it costs around $40 at a pharmacy, so it's not cheap. I think
Is that the Now DX?
yes.
Yeah, I think it's like 20.
Okay,
But I
$20.
think, yeah, because I feel like we got, yeah, it's something around that, but I can't vouch for that because I've actually never seen it on the shelf. I thought that the OraSure was a lot cheaper than it is, and it retails for like $47 for very unclear reasons.
Yeah. So thanks, Yuka. So the short answer is that I haven't used it. I would certainly use it in some of my patients who are on PrEP, for example, who find it difficult to attend for STI testing. I think it's it's far from perfect, and it definitely has limitations. But I think any tool that we can use that's going to allow us to diagnose syphilis earlier, decrease morbidity within the individual, prevent onward spread, and hopefully bring them into a clinical encounter should be encouraged. So I'm all in favor of it. I haven't used it yet, but when I do, I'll be sure to share that experience.
That's great. And then there's a question from Emily in the chat about what would you say to a patient who has a new fourfold increase and is anxious about waiting 2 weeks to repeat an RPR and would want an answer or to start treatment sooner than that?
Yeah, I think that's a really great question, Emily. Thanks so much for asking it. I was going to try and squeeze it in to the presentation, but there wasn't time. You know, I think that this 2 week cooling off period is really helpful because I've so many times seen that RPR come back down and that person has then avoided unnecessarily heartache and unnecessary treatment and the implications that a new syphilis diagnosis can have on a relationship. But I'm also aware that there's heartache and anxiety in waiting. So what I do is to individualize that decision. You know, I look at the pretest probability that this person has a treatment failure or a new infection, and also their ability and willingness to come back to the clinic. So if you kind of think this person's going to be really stressed out and not going to come back when you find that their RPR is, you know, 16 times higher, then I think it's completely humane and legitimate to offer treatment on that day.
Great. Well, we are at 1 o'clock. So unless there are any other burning questions, as we say in the STI world, we'll just say thank you so much, Matthew. This was amazing. Yeah.
Just to let you know that if anybody wants to get a Now DX, you can, and you live in Baltimore City, you can get it through I Want the Kit. If you get it, you will get a follow-up phone call, however, to see how you found it how you found it for use. The few people that we have used it so far have found it very easy to use, but you can get it for free. Of course, if you have already had syphilis in the past, it would not be a very useful test.
Right.
So in that case, you'd not be able to order it.
Got it. Well, thank you, Yuka, for that. And everyone have a wonderful weekend, and we'll see you next week, hopefully many of you in person, when Joel is promising to talk about more than just the mutations, although I would show up for the mutations. There will be more than just mutation talk next week, so please do join us for that. Thanks, everyone.
Bye.